Test, test. Thanks. All right, here we go. Again, my name is Colt Martin. I'm just doing this for the video. This is my thesis presentation for RES 505. And it's the benefits and barriers to implementing an atrial fibrillation program. Just to give you guys a little bit of background how I came about on picking this topic. Obviously, most of you know I'm a registered nurse. I've been cardiac's my background. Been doing that for 9 years. Did a cardiac cath and EP, as well as emergency room nursing for an additional 2 years. So cardiac's been my background. Last year, when we first came together, I had just got a new position within my company for starting an arrhythmia program within our hospitals. So I've been working with 7 of our 16 hospitals so far on implementing a AFib program, and to date, we'll discuss in a few minutes, there isn't a national standardized program for atrial fibrillation patients or arrhythmia patients when they come into the hospital. So there's chest pain, there's stroke programs in place, but nothing's been implemented yet for atrial fibrillation program. So what is atrial fibrillation? Atrial fibrillation is one of the most common arrhythmias in the United States, with around 6 million people worldwide affected by it. And it's quivering in the upper chambers of the heart, so the electrical impulses are firing rapidly, so your upper chamber, your atrium, is rapidly going erratically, and it's not appropriately going down to the ventricle, so you get pooling of blood. So that's where AF can lead to an increased risk of stroke because of blood pooling, forming clots, heart failure due to the rapid beating of the atriums, causing scarring of the muscle, and also increased mortality due to heart failure and stroke. From some of my data, we'll go into that, hospitalizations have increased by 23% over the past 10 years related to atrial fibrillation patients. And one is because I think more awareness is being brought about to atrial fibrillation, but also, again, there's no standardized program, so I think that's why we're seeing more hospitalizations, because people are diagnosed with it, or they just start having a fast heartbeat and they go directly to the hospital. With that increase in patients coming to the hospital, you see increased economic burden on the healthcare system due to the recurring hospitalizations and length of stays related to these patients. So the research idea that I formulated for this was, it's a little long. The number of Americans diagnosed with atrial fibrillation has multiplied over the years, but no standardized program, thank you, has been made within healthcare institutions. New medications, treatment options, and guidelines have been developed to manage this disease process, yet institutions have not made the adjustments to their programs. So healthcare institutions must institute a standardized program to effectively manage and treat this growing population, and also physicians must incorporate the most up-to-date treatment guidelines within their daily management strategies. And we'll discuss some of the barriers that I've come across with that. So the problem statement, very similar. AF patients are undiagnosed and mismanaged from onset of the emergency department through admission to the hospital due to a lack of a quality standardized program. No identified programs have been recognized regarding identification and treatment of AF, atrial fibrillation patients, within our healthcare system, which in turn leads to potential increase for stroke and also higher readmission rates. So the methodology I used for the research was a non-experimental approach. Obviously, we did a meta-analysis of existing data. So I just mentioned a couple of the studies that I've used, and I'll briefly just touch on them. So it's Kalila talks about the prevalence of AF in the United States, and that really touches on ICD-9 codes, which are diagnosis codes for each disease process. So it took the specific diagnosis code over a 10-year period, and that's where we're seeing the trending of the population increasing. The second study is the Patel 2014, which talks about the trends of hospitalization AF, and that's where we really look at the readmission rates, mortality, the risk of stroke, and then also the healthcare costs and burden that have increased over this period of time. The last one is a study that really talks about the guidelines of management of atrial fibrillation, which I'll touch on a little more. But what that study is, evidence-based guidelines are kind of the formulation of a quality program, and this guideline for atrial fibrillation patients came out in 2014, the newest version, and this is over 85 clinical trials, including 30,000 patients that were randomized on different kinds of medical treatment therapies and treatment strategies for patients to find out what's the most effective and the results of that. Two surveys that I use really to look at the barriers to implementing evidence-based guidelines and protocols on a physician basis were the UBINC and the Mosca study, which talks about what are the barriers to implementing the evidence-based guidelines within practices and healthcare institutions, and then the second was physician awareness and adherence to cardiovascular guidelines. So that was a 2005 survey, and then lastly there were case studies built into the guidelines that I talked about from 2014 that talk about atrial fibrillation. So what are evidence-based guidelines or evidence-based practice? Evidence-based practice is an explicit and judicious use of current best evidence in making decisions about the care of the individual. The governing bodies for at least on the cardiac side institutions is the American College of Cardiology and the Heart Rhythm Society. And so they really came together, collaborating and getting all these 85 clinical trials to really put together what's the best practices and what's the best evidence-based medicine to use in atrial fibrillation patients. So this is just one of the tools I just wanted to show you. It's called a CHADS VASC and a HAS-Blood score. It's just a risk assessment tool that's really used to identify patients at risk for stroke and atrial fibrillation. So this is just one of the evidence-based guidelines proven to decrease a patient's risk of stroke when they have the score calculated, and then if they are at risk, they are put on proper anticoagulation. So it doesn't completely eliminate their stroke risk, but it does identify their risk for stroke in the AF population, and it gives you indications for putting them on proper anticoagulation, either Coumadin or a lot of these newer drugs that you guys might hear on, like Xarelto or Pradaxa or Eliquis. So the second is different treatment strategies. So when you have somebody with atrial fibrillation, when they come into the hospital, there's only two types of strategies. One is a rate control, where you're trying to keep their heart rate down and not necessarily putting them back into a normal rhythm. And the second is a rhythm control strategy, where we use different medications and treatments to get them back into a normal sinus rhythm, because the studies have shown that people that are in normal sinus rhythm long term have a lower mortality rate than those who are in AF. So this is just a treatment strategy algorithm that the governing board kind of put in place, and that's what we've used to incorporate into the program that we've done in 7 of our facilities. So what is the gap? One of the most consistent findings in health services research is the gap between best practice and actual clinical care. So studies within the United States and Netherlands suggest that 30 to 40% of patients do not receive care according to current scientific evidence. So these are the things that were identified within a couple of studies that I looked at. So it impacts physician workflow. And that's because you're implementing new practices to a physician or new guidelines or treatment strategies, but a lot of physicians kind of want to do what has worked for them in the past. They don't want to, even though there's evidence behind it, it's going to interrupt the workflow that they already have within their practice. The second is a lack of knowledge. You wouldn't think that a physician would have lack of knowledge, but we have so many subspecialties. So a family practice physician seeing a patient with atrial fibrillation is different than a cardiologist treating a patient with atrial fibrillation, because the subspecialty focuses, the cardiologist on looking at the most up-to-date guidelines for that disease process or function in the cardiology setting. Implementation costs anytime within a healthcare institution or in a physician practice. If you're having a new standard or new program in place, it's obviously going to be more of a cost, either due to implementation of the program or due to allocating more resources within the institution. Right now, there's no negative impact or penalties by government institutions related to atrial fibrillation and arrhythmia programs. There are standards in place for stroke and heart disease, but nothing's in place yet for AFib, other than readmission rates, Medicare reimbursement, and penalties on 30 days. And then lastly, physician rebellion. Physicians, from the surveys, it was said, physicians don't want to be told what to do, so it's a matter of kind of changing the culture, which we'll touch on in a minute. So transformation, what's been needed throughout this program that I've been working on within our institutions, and obviously leadership is key, and leadership, as we see in Hickman, it's really the composition and the structure and the process that is put into place, because the leader needs to help give the vision and the drive and the direction for the rest of the team and organization. Second is a culture change. Again, identified that obviously this is new for physicians and organizations, so there's a little bit of a change in culture, especially when you're trying to implement new things, when there's a pushback, even though there's clinical data to support it. So openness, trusting others, and teamwork we have identified as obviously key areas to really building those relationships with the physicians, showing them the clinical data to kind of say this is what's going to be best for the patients long term, and look at the quality measures of that. Lastly, last two things are communicate, and as we've seen in Wheel, and high-performing teams have an open communication structure that allows all members to participate. So we've built a collaborative team approach with physicians, administration, nursing, and a lot of the other personnel, so we can come together and talk about how do we define some of these key areas and what we need. And then lastly, we need evidence-based data to show higher readmission rates, length of stay, decreased quality of life in these patients that will help kind of turn the tide. So the AF program that we implemented was a multidisciplinary collaborative team approach, and again, it included those people that I stated before, and that was really to identify the key strategic areas needed to identify the AFib population. Patient identification, really built the treatment and management flow charts off of the 2014 guidelines from the American Heart and Heart Rhythm Society. So we really got the physicians' buy-in and input on what's going to be the best practices that that they've said that we're going to use within our institutions. Order sets and education were pieces that we built, and then lastly was patient follow-up. So we have a nurse follow-up system built in so that we can one, educate the patients, make sure they understand their medications and the disease process, but also help them get to their follow-up appointments so that they aren't coming back to the hospital and we're getting dinged for those readmissions. And lastly, data-driven. Everything that we've been doing within the 7 hospitals, we've been collecting metrics that we've kind of identified as key areas that we want to measure. So length of stay, risk stratification on assessing the patient's risk for stroke, and then also readmission rates for some of the top 3 things that we focused on. So the focus with the AF program, and some of the studies in Canada have talked about this in the past few years, is really moving this from an inpatient strategy to an outpatient management algorithm, and that's really to reduce the readmissions, but also get the specialists involved. So as I mentioned, AF, there's no standardized program, so with chest pain, when patients come into the hospital, they're treated by a cardiologist, interventional cardiologist, because that's their specialty. If somebody comes in with a stroke, they're seen by a neurologist. When somebody comes in with atrial fibrillation, anybody can take care of it. So even though we have specialists for these other things, there's nothing for the arrhythmia population. So that's where we're really trying to get specialists involved soon in the care of these patients, so that we can really kind of hedge the gap. So reduce the length of stay through the guideline-driven care and time management. Quality of life through identifying the stroke risks and getting them properly anticoagulated. We're assessing functionality scores. There's a quality of life assessment tool that we use for the patients. So they tell us how they feel walking to the mailbox and back, and seeing if we're actually helping them, or if we need to try a different strategy. And lastly, one of the main focuses is physician engagement, which is the relationship and trust. Performance measures, because there's so many metrics out there for the physicians. But lastly, you have to incentivize the physician, which we haven't built that process yet. But as we grow the program, incentivizing the physicians to follow the quality measures is going to be key to getting the program moving forward. So the conclusions for my study is evidence-based guidelines. One, they're beneficial in management and treatment strategies. It's a financial benefit to the healthcare institutions because we're moving it from an inpatient strategy to an outpatient, reducing the readmission so that you're not having that 30-day penalty within the hospital. And then also from a cost perspective, for getting them in and out, giving them the appropriate treatment, we're going to decrease the overall cost of that patient. Some of the barriers that we have identified is additional resources and cost. So obviously, we want to look at the big picture. Obviously, on the front end, you're going to put some resources into it, but it's necessary to make it at the end. Second is a change in practice for physicians. So that's going to be a key area that we're working on overcoming, and that's really a one-on-one with physicians. And lastly is leadership is necessary to give the focus and direction for this program, and the leadership within the hospitals and administration to help facilitate with the physicians. The collaborative team approach is key because you're inclusive and not exclusive, because that really gets the buy-in of everybody. And lastly, the trust, communication, and honesty is key for that. And I'll close with, I think I have some biblical truth on there, just on wisdom. I love, James 1:5-6. If any of you lacks wisdom, let him ask God, who gives generously to all without reproach, and it will be given to him. But let him ask in faith, with no doubting, for one who doubts is like a wave of the sea that is driven and tossed by the wind. And so, one thing is just wisdom on my part and direction on where the Lord's leading me, even though this is a world problem that I'm working on. Obviously want to get the wisdom from God for that. And the last two things are leadership and integrity, and you can see on 1 Samuel 12:24 and Proverbs 10:9. I won't read them for you. You can see them there. But the one last piece I just want to talk on is that I'm working on with this program is once we show the data, which we have within 7 of our hospitals. So the 7 hospitals I've been working in, we've been collecting data specifically on the the atrial fibrillation patients coming in that have shown, a decreased length of stay, a decreased readmission rate, not so much a decrease in the short-term healthcare costs, because we are doing, some more procedures and other things. But I think on a long-term basis, as we kind of, look at this analysis later on, maybe in a 3-year study, we'll be able to see that there is a long-term decrease in the healthcare costs related to those patients. And then moving forward, taking that to a lot of the managed care insurance companies to really say, this is a program that we have in place to really, make it better for the patient's quality of life. We're better than the other hospitals. They don't have this program, and then encourage the physicians, one, to be a part of the program, because the insurance companies can force the physicians to because there's a lot of managed care practices out there which are capitated and they get paid not to do anything for the patient. So anyways, I just wanted to close with that. So thank you.